Welcome, everybody, to our February conversations on brain health. My apologies, first and foremost, for being 2 minutes late. I try to stick to the Swiss standards of being right on the hour, so apologies for the 2 minute delay. I am super excited for our discussion this evening and to be joined by urology. This is a topic that I feel has not gotten enough attention and obviously doesn't get discussed enough. So I'm really happy to have two experts with us this evening from urology. Um, First and foremost, my name is Catherine Kiefer. I am the neuroscience program manager at Rush University Medical Center, as well as a co-founder and president of the Brain Health Center of the Rockies, a 501c3 nonprofit organization. So for this evening, we will dive into bladder, gastrointestinal, and sexual dysfunction, which can be symptoms of multiple sclerosis, and oftentimes can be difficult and uncomfortable to discuss. So, so happy that we will be jumping into this topic this evening. It is an important area to bring this up and discuss for overall just quality of life. So we have Dr. Sarah Adelstein and JD Golon, who will be sharing with us what to expect during a typical visit with urology, why bladder and sexual health are important in multiple sclerosis, common treatment options, and practical lifestyle strategies that may help with managing symptoms. So, as with all of our conversations on brain health, of course, I want to make sure I give proper introduction to our speakers this evening. So, Dr. Sarah Adelstein is an assistant professor of urology at Rush University Medical Center. Her clinical and research interests include urodynamics, voiding dysfunction, neurourology, and pelvic floor disorders. She earned her medical degree and completed her urology residency at New York University, followed by a fellowship in urogynecology and reconstructive pelvic surgery at Virginia Mason Medical Center in Seattle. She serves as director of the program for abdominal and pelvic health at Rush, as well as the vice chair of clinical operations and associate program director for the Department of Urology. Dr. Edelstein, I think it's kind of cool. You went from coast to coast and landed in the middle of the country. So we're so happy to have you at Rush. Um, our second speaker for this evening is Jeremy D., also goes by JD. Golon is a physician assistant specializing in men's health, infertility, and sexual medicine in the Department of Urology at Rush. He graduated with honors from Rush University's College of Health Sciences with a Master's of Science in Physician Assistant Studies, undergoing an extra 4 months of training dedicated to urology. He is an active member in the Sexual Medicine Society of North America, American Urologic Association, and the Chicago Urologic Society. So two fantastic speakers with us this evening. So fortunate to have you folks with us. For all of our conversations, if anybody is new starting with us this evening, we always like making sure that these sessions are interactive. So there should be a chat box or a Q&A at the bottom of your screen. Feel free to type in any questions that you have, and we'll pause throughout this 1 hour time frame to answer as many of those questions as we can. So on that note, I would like to start it out by just asking a few questions around why are bladder and sexual symptoms potential problems for people with multiple sclerosis? How does that brain, spinal cord, bladder connection work, and what goes wrong in MS? So I will turn it over to you, Dr. Adelstein.
All right. So my expertise is definitely much more in the voiding side of things. So I'll maybe talk a little bit about that, and then maybe JD can pipe in and fill us in on the more sexual side effects of all that. So as a urologist, my understanding of neurology is quite simple. Okay, but the way I sort of explain this to folks is any process in the brain, um, whether it's something like multiple sclerosis or brain radiation or trauma or having had a stroke, okay? Any of those things can result in letting the brakes off with regards to how the brain treats bladder function and lead to essentially overactive bladder style symptoms, okay? So there's many different parts of the brain that input to the brainstem where all this bladder function is kind of coordinated. And so any interruption in those circuits basically ends up in the bladder is a little oversensitive. Right? People feel the urge or the need to urinate when really and truly there's perhaps only a few ounces in the bladder. So those inputs are constantly coming from so many parts of the brain that basically any interruption in those circuits is going to have the same result. Okay. Frequency, urgency, nighttime urination, urine leakage, especially with that, like, gotta go, hurrying to the bathroom, or as I say to patients, gotta go, already went. All right. That whole spectrum of symptoms can come up in MS that's affecting the head. When it comes to the spine, things get a little tricky. Okay. And so those symptoms I just mentioned, I think something like 75% of folks with MS describe some kind of symptoms on that overactive bladder spectrum. Those who have spine involvement of MS can get interruption in the circuits that control our coordinated bladder function, where like the bladder is squeezing to push the urine out, and at the same time, our sphincter muscle, the control valve, relaxes to allow bladder emptying. Okay, so the bladder squeezes, the sphincter relaxes. You don't have to think about it. It magically happens. But if there's any, spinal inflammation, injury, surgery, radiation, right? Anything going on in the spine, that very sensitive, sophisticated circuitry can get interrupted. So a small percentage of folks with MS can have a problem where the bladder's trying to urinate and the sphincter muscle is actually doing the opposite of what it should do. It squeezes against the bladder. And this can lead to very different symptoms: straining with urination, not emptying the bladder, high pressures in the bladder that actually impact the kidneys, painful urination, infections. And this, group of patients are actually like a group I worry about a little because, as I sort of alluded, it's impacting kidney function. And that's, not something we want to miss the boat on, right? Protecting kidney function over people's lifetimes. So not only is it a symptomatic bother, but it's possibly a threat to kidney function. So that's kind of very generally how I think about the different bladder issues that can come up with MS. All right,
Excellent.
JD.
Thank you. Thank you, Dr. Adelstein. That was very clear and great seeing you, by the way. Sorry for joining a little bit, few minutes late. But so this is helpful. But if you can probably dive in a little bit more into the symptoms. Sometimes patients, attribute some of these symptoms as, well, I had a couple of babies and pregnancies, and I'm also getting old. When should I worry? In the case of a female or in case of a male, maybe my prostate is in the way. So when would you recommend patients to discuss this at least with their healthcare provider?
Yeah, excellent question. And I'm going to say, like, some of that framing, I would almost even say, forget about it, right? Like, if you're having bladder symptoms that are bothersome, that are holding you back from doing activities you enjoy, or holding you back from socializing, getting out of the house, right? It doesn't matter why they're happening, right? It doesn't matter if it's from MS or having lots of babies or menopause or other medical problems. That's a good reason to come see us because there's something we can do. And to some degree, sometimes the reason for the symptoms, it's always multifactorial, right? It's always multiple things, and it's stress, and it's constipation. Like, oh, it's usually from several different things. It can be from S. But there's something we can do to help no matter why people are having the symptoms. So the time to come in is when it's bothering you, or if you're in that batch of folks who are getting recurring bladder infections, recurring kidney infections, blocked kidneys, swollen kidneys, not emptying the bladder, those are also reasons to come see the urologist.
And if you have that granular data, that's like the more pressing need to maybe get an urgent urological referral.
Excellent. So what I'm hearing from you is not only the presence of symptoms, but then how the magnitude in a sense, right? So how much these symptoms are interfering with your life. And, the classic example of that is sometimes symptoms outside of the bladder. I frequently talk to patients who are tired during the day and they have this somnolence or they are fatigued during the day. And you start asking questions and apparently they have to wake up 2 or 3 times in the middle of the night to empty the bladder. And they have interrupted sleep, and that leads to daytime somnolence and sleepiness. So sometimes the bladder is also the reason why people are tired in the day. So I will say what I'm hearing from both of you is have a low threshold for maybe consulting with a urologist. Is that correct?
Yeah, absolutely.
Absolutely. And I think a consultation with a urologist tends to be a conversation, right, about the whole spectrum of symptoms that are going on. Some assessment of kind of our urology vital signs, right, how the bladder's emptying and things like that. And then we can kind of lay out everything we have to offer. And, I think there's a difference between, right, like, are we treating symptoms that bother you? That's one conversation. That small batch of symptoms that, I don't care how much it's bothering you. If it's hurting your kidney function, I'm really worried, right? And that's like kind of a different conversation. So, but I think, there's no obligation to anything. It's an assessment. And if we can find some, conservative measures or treatments that sound helpful, great.
Are there any particular tests during a urology visit that might be uncomfortable, and how should a patient perhaps prepare for that?
So I'm going to say in my office, because I have this kind of joint background of urology, neurourology, and urogynecology, and symptoms do tend to be quite multifactorial. Most women who come to see me, I'm going to be doing a very basic pelvic exam, right? I mean, we're talking about genitourinary symptoms, and so doing an exam of the relevant area is part of the evaluation. So, we're not doing pap smears, we're not doing gynecology care, but we're sort of assessing why the symptoms are happening, and that includes an exam. For men, there may be a rectal exam. It's not actually always relevant. So I know, like, historically, right, that when people are afraid to come see the urologist, men didn't want to get an exam, and I would say that's not happening at every single urology visit, so it's not always necessary. But if we hear something that makes us think it's necessary, that may come up. Other routine urology assessments would be a urine test, okay? We use a little ultrasound in the office to assess whether the bladder is emptying fully. I would say that's a pretty routine part of a urology, first visit.
Excellent. And speaking on visit, and I can see already the questions coming in, so we'll get to those in a minute. So please, for our audience, feel free to continue to ask these questions. This is for you, as Kathy mentioned. But in order to be better prepared for that visit, what type of information would you say is critical that patients bring to you? I mean, the one that I can think, is medications. Those are things that actually, what medications are you taking or what treatments have you tried? But the other one also, I often hear the water intake. One of the coping mechanisms that some patients with frequency or urgency do is try to dehydrate in order for the, bladder symptoms not to interfere with a long trip or whatever activities you're trying to do. So, besides, medications or water intake, what type of information would you say is critical or very relevant for patients to bring to that visit with you?
So So certainly like fluid intake and what kinds of fluids we're taking are something that we'll be talking about. But in terms of like preparing and bringing, yeah, medications, pill bottles if it's too much, or if you're new to rush, is having the full list and bottles handy. It's nice to know if there were past urologic medications. Maybe you don't take them anymore. We'd love to avoid repeating things we know did not work. So if that's handy, that's nice to have. And for those who are getting infections, like I'd like to have access to, what have the urine test showed. So I don't need tests from 10 years ago, but like anything in the last year is nice to have handy. Fortunately, in 2026, a lot of stuff is available in the medical records somewhat readily, but not all urgent care centers, right, are like on the same interface. So that would be worth gathering together if that's a relevant part of the symptoms.
And I know there's a question in our chat box already just about treatment options, and what would you suggest are some of the best treatment or some of the main treatment options available?
So I think, when it comes to the patients who have, I say straightforward, but the symptoms that are more like frequent urination, urgent urination, leaking, I gotta go, I'm peeing several times a day, I'm peeing multiple times at night. For that group of patients where we're not worried about, straining, weak flow, poor bladder emptying, there are a lot of conservative treatments, but my general spiel is going to involve a talk about fluids, right? Dr. Miravalle kind of mentioned this. If you are somebody who drinks 100 ounces of fluid per day, you're going to pee frequently, right? There's nothing I can do about that. But if you're someone who drinks 20 ounces of fluid a day and is still peeing frequently, I'll tell you there's no perfect number, but there is a bit of a happy medium when it comes to fluid intake. So like, I don't know, 8 glasses of water a day is a made up number. It's really not that relevant for folks. But I think if you're restricting fluid so much that your stools are hard and frequent, the urine is gold all the time, you're too dehydrated. That can actually make the bladder urgency frequency worse. Okay. So, when I get folks who are on those extreme ends of the fluid intake spectrum, usually I would recommend an adjustment. Some fluids irritate bladder urgency more than others. And I have a long list I give out, and I like to say, like your bladder didn't always read the textbook. Maybe there's 1 or 2 things on this list that stir up frequency urgency for you. It might not be everything on the list. But this list is things like coffee, caffeine, acids, so like citrusy drinks, orange juice comes to mind, sparkling drinks, right, like soda, sparkling water, that's all carbonic acid. Some people are very sensitive to those things, and it can make urgency frequency worse. Herbal tea, right? It's not caffeine, but I think a lot of herbal tea does tend to have a bit of a either diuretic or urge effect. So those are things to kind of think about. And I tell people to do an experiment, cut it for a couple of days, bring it back. If it makes no difference, then great. Constipation is a very common co-symptom, and it's really related. So the rectum and the bladder share nerves. If the rectum is constantly telling the brain, I'm full, I gotta go, I gotta go, you don't have 2-point discrimination in the pelvis inside, right? So sometimes the bladder frequency urgency is happening because the brain can't really tell the difference between the rectum is full and the bladder is full, and they tend to come together. So I think I talk to folks about bowels more than any not GI doctor because it comes up a lot, right? Yeah, JD knows what I'm talking about. So, conservative stuff would be like water, fiber, right? Like women should be getting something like 25 grams of fiber per day. Men need like 30 to 35. That's a lot. That's definitely not the American diet. Some people need stool softeners or gentle laxatives, right? The older we are, the slower the bowels are. Medications you take, half of them cause constipation, right? And we just want to combat that and keep the bowels regular, meaning like a formed bowel movement that's easy, like at least every couple of days, if not every day, right? So straining, pebbles, those could be better. All right.
I love that question and the comment about the diet because, again, we are a brain health conversation series, and it seems like every topic we choose, no matter what, ends up in the importance of nutrition, diet, hydration into our health, right? Maybe can you expand a little bit more on the typical nutritional components that are recommended? And you mentioned fiber and hydration, but also the components that actually perhaps are not recommended, particularly in that period in which you're symptomatic and you're trying to figure out, how the magnitude of these symptoms, perhaps things to avoid.
So the dietary stuff, right, again, there's like fluids that cause urgency that are not universal, okay, but coffee, caffeine, sugary drinks like juice, soda, anything acidic. So that could be citrusy drinks like lemon, lime, orange, grapefruit, anything sparkling has acid in it. Even herbal tea, I mentioned, right, like sometimes can have this kind of urge effect. Spicy foods, chocolate, okay, all these things can drive bladder urgency. And then separately, right, things to maintain bowels would be more like the water, the fiber. We don't want to be drinking so much fluid that that's making you urinate all the time, but I also don't want folks so dehydrated that it's making the constipation worse. The urine is very concentrated and salty, and I think that all by itself bothers the bladder. So like nutrition wise, those are the main things I talk to folks about. And I know for sexual health, this is also super important. JD, do you want to jump in and talk about kind of
Yeah,
like optimizing sexual health?
yeah, of course. So, the MS patients that I see in my clinic, obviously we do they kind of end up there because we prioritize more of the urinary symptoms that can happen. And we want to make sure that the kidneys are being protected and you're not having any changes to kidney function or having urinary retention, which will overall worsen bladder health. So the sexual stuff kind of ends up being just a part of the conversation that if it is something that is bothering one of my patients, and they happen to be the person in our department who kind of um, has the expertise to kind of help people with it with some more advanced treatments and can have like a little bit more of a detail oriented conversation about your options. It strikes me that, just kind of preparing for the kind of this conversations that it was estimated between like 50 to 80% of people with MS have some type of sexual dysfunction. And the most recent meta-analysis I found, it had a less of a range on that, but it's still just as high. So, for the physicians in this crowd, and of course the patients, it is more likely you will have sexual dysfunction than not. And MS is a condition that we can treat. So thus is it expected that, you can age, and age is also a risk factor for sexual dysfunction. But there's a little bit more unique ones that are much more annoying to your quality of life that can arise with multiple sclerosis, and that's specifically urinating when you don't want to, and when you're with a partner. A lot of that we kind of categorize that as coital incontinence. So that can occur with arousal or it can recur with orgasm. We call that climacturia. And, kind of specific to what Dr. Adelstein was talking about, that does kind of go into, we want to see if there is some type of, certainly could be like a primary area on one of the nerves that are kind of being affected by your MS, but there's always a component of the bladder muscle probably being overactive and maybe an issue with the sphincter being weaker. And these would be things that we would want to address firsthand with this. So we can kind of actually give you the type of treatment that would help you with this. And in some cases, these do kind of end up being procedural or surgical options. And as we were kind of talking about, a lot of these options that we have, these are somewhat of a quality of life issue. So as it's not, you're not going to hurt yourself long term if you don't do anything about it, but that can sometimes make it a little bit more of a overwhelming and complicated conversation, because you kind of need to decide which of the risks and benefits associated with these treatments are best for you. And sometimes it takes more than one conversation or visit with us to kind of figure that out. And that's absolutely fine. We want you to kind of go into deciding how you want to treat that very clear-eyed. But specifically things that are that can help with some of the incontinence that you feel that are not procedural. We certainly have a lot of these medications that significantly overlap with like overactive bladder. And the older generation medications, they do come with a lot of side effects, and some of these side effects can kind of worsen some of these situations that you're experiencing if you have bowel symptoms. They often can cause constipation. It can cause dry eye and dry mouth. So these side effects may be superimposed on the what your symptoms of your multiple sclerosis can be. However, you just need to kind of weigh that against how much these symptoms really do affect you. Now, as aging populations for both men and women, men will develop erectile dysfunction, and you can kind of think of it as about for every decade of life, once you're at age 50, that's how much the percentage of men correspond to having erectile dysfunction. So if you're in your 50s, about 50% of guys have erectile dysfunction. If you're in your 60s, about 60%. And the options we have to treat that, they don't really change compared to somebody that doesn't have MS. It's just giving you a medication that can help give you more opportunities to develop an erection that's rigid enough for you to participate in penetrative intercourse. An interesting thing here about these medications too is that there's some overlap with potentially helping some of your urinary symptoms. So it's somewhat off-label to help with a little bit of urinary urgency, but there's some okay data that says it can be very helpful, and I'd say that's a good place to start if you're somebody who's very averse to medicine and doesn't want to have a lot of different side effects associated with that. In addition, men will have like a prostate. They have this little organ that we really focus on in urology that really does some annoying things to men as they get older. Often it can get bigger and it can grow inside of the bladder and compress the urethra and also worsen bladder function and result in a number of these lower urinary tract symptoms. The other options that you end up having for erectile dysfunction, they end up being vacuum erection devices, which is exactly what it sounds like. It's a plastic cylinder that fits around your penis and provides negative pressure to your penis, and you put a band on the base of your penis, and it can kind of give you a rigid enough erection to have sex with. I'd say for many people that have MS that are resulting in some disability issues and would probably correlate with more of a neurogenic, maybe related erectile dysfunction. So some of these medications are not going to be very helpful for you because there's an issue with the wiring essentially between your brain and your arousal nerves. And what we have that's very effective for that to give you an on-demand erection is an injection that you would do into the base of the penis about 10 minutes before sex. How they work is that it's a medication that contains three different types of medications that result in increased blood flow to the penis. So it bypasses the nerves that you have. And it works very, very well. Sometimes it works too good, and the main side effect is it can give you an erection that does not go away. But if you use that medication responsibly, it's a well below 2% risk of that happening to you. As far as women go, many women that usually come into my clinic that have MS are going to be over 45 and are firmly within probably the age group of being in perimenopause or menopause. And what that can lead to is a lot of vaginal dryness and irritation. And I'd say the single most effective medication that every woman should consider being on when they're around that age is to use topical vaginal estrogen. I think there was a landmark ruling by the FDA recently, probably one of the only few things that I agree with that the FDA is doing relatively recently is they took the side effects, the black label warning on the side of the label of estrogen therapies for menopause off, and those were associated with estrogen sensitive cancers and the risk of clotting events. So all those were removed, and for a long time, many women were afraid to kind of start these medications for that reason. And at a significant disservice to many women because this medication is very useful for helping overactive bladder symptoms. as well as those women that have recurrent urinary tract infections that are around perimenopause or menopause, the urinary tract contains a very high density of receptors sensitive to sex hormones. And a lot of these changes that can happen in menopause can put women at risk for developing urinary tract infections as they get older. Additionally, so it would help with vaginal dryness and irritation. And if there is any pain with intercourse, that is upon entry or during. Very useful medication that I think these two, for men, you can kind of consider the phosphodiesterase 5 inhibitor as a good thing to maybe start in your 50s to help with urinary symptoms as well as erections. And for women, the topical vaginal estrogen is a very simple and safe place to start. Both of these medications are probably the safest thing that anybody could prescribe a human being. I know you gave me a full list of these questions here. I was trying to do my best to give people a very things that they can consider right away to kind of simplify it. So.
I love it.
I think that's fantastic.
Started and ended, JD, was also reminding me pelvic floor physical therapy is just
absolutely. Yeah. So, and I know there were some questions in the chat about that.
Yeah.
So that is probably it's going to take more than just your neurologist and your urologist if you develop a relationship with one to help you through these things. And certainly it is, a condition that is very frustrating for you. Really kind of changes the way that you interact with the world and your relationships with your loved ones. But pelvic floor physical therapy is enormously helpful to address voiding symptoms, but also any type of issues that arise with sexual dysfunction. So that may involve the inability to orgasm, or for men, the inability to ejaculate, or you're too short to ejaculate and feel an orgasm, or it takes you too long. Pelvic floor physical therapy can help you with these things. In addition to that, too, I'm a huge advocate of those to develop a relationship with a sexual wellness therapist. So it's a specially trained therapist that can really help give you some other solutions that are non-medical to address a lot of these symptoms. And this is kind of the conversations that they have. They're a lot more well-versed in the sexual wellness tools or toys you could kind of think of. But there are many things that are very helpful in this world for women in terms of vibratory stimulation, and also men as well for these things. And the nice thing about all of these options too is that health savings account and flexible savings account are accepted to pay for these things. So if you are having issues with sexual intercourse as you get older, and very good idea to maybe consider these non-pharmaceutical approaches to help you with it as well.
Thank you so much, JD, for really diving into this. I think for many people, sometimes it can be overwhelming, and you just touched upon the fact that there's physical, pelvic floor, PT, there's urology, there's sexual health specialists or gynecology. If somebody just wants to kind of start those conversations, what might be the best path for them to take?
Yeah, that's a really good question. And I recognize that not everybody is equipped to, give you the tools and to help with all this stuff. I think certainly, the way that I try and approach it with my patients is just try to be as non-judgmental as possible. And I want people to trust me, so I can do a better job for that. But I think at the end of the day, the best way is to trust your provider. Let them know that it's something embarrassing to you, and it's important for you to at least have a conversation with somebody so you can treat it. I know for the providers in the audience, if you're there, the neurologist, you're going to have a lot of follow-up with your neurologist while you're treating this. So you're going to develop that longitudinal relationship with them. And with that is, it only comes with comfort, right? And you may not be ready to bring it up to somebody, but, in the future, again, somebody is always going to see you. And I think it's important to at least say it in a way that hey, this is really bothersome to me. So you can at least get referred to somebody who may have the skill set to help you with these things.
Mm-hmm.
And that's
Yeah.
actually reminds me of a study that we did once looking at overall health in MS patients versus healthy controls. And actually, MS patients, when they have access to healthcare, they end up having better health because, they see so frequently their
Right.
neurologist that sometimes triggers seeing a urologist. And by the way, I saw you for my bladder symptoms, but let's just do it, check for prostate cancer, right? So it
Yeah.
becomes this cascade of events that when patients have access to healthcare, which unfortunately not everyone does, and they are actually on top of it, they could end up with better health. But something that you mentioned, and I really love how this flow of conversations is going. We talked a little bit about medications, we talked about nutritional, we are now discussing pelvic floor exercises, perhaps non-pharmacological approaches also for sexual health. Let's now talk about more the invasive type of management. I know that the use of catheterization sometimes is frequently a tool, the same with Botox injections. What can you tell us about your experience and again, how early is too early versus maybe wait until things become more difficult to manage?
So,
Sarah, do you want to start? Yeah.
yeah, I mean, I think, when it comes to catheters, most urologists would say, indwelling catheters that go into the bladder are really a treatment for urinary retention, okay? Not for frequent urination, not for incontinence, but for people who can't empty and they need that catheter to kind of bypass the urinary tract to get the urine out. And I think, I don't know, 50 years ago, or if you're just at home, but I'd rather have a catheter than be sitting in diapers. The problem is, catheters, if you don't need it, right, there is a small risk of urinary tract infection. There is, some irritation that happens. A catheter has a balloon that sits in your bladder. That's what holds it in place. If you're someone with a lot of frequency and urgency, sometimes that balloon is really storing that feeling up and making it worse. So it's not a cure-all, it's not for everybody, but if there's, enough urinary retention that either infections are happening, kidney function is being impacted, or, you're urinating every 30 minutes and we realize it's because the bladder's just not emptying, you're getting 10% off the top, but it's all stuck. Catheters can be helpful in those kind of situations. For folks who are dealing more with leakage but empty their bladder okay, and I'm going to caveat and say this is not something you can know about yourself. It's actually something we really have to check, either with ultrasound or a catheter, right, to see what's left. So a lot of patients will get the feeling like I urinated and I still feel like there's something there. And sometimes it's just that urgency, that bladder oversensitivity is so severe that the 1 ounce or less that's left after urinating, which is normal, is causing this sensation that's way out of proportion, right, to what's really there. So sometimes people feel like they're not emptying, they are. So it's just something you may think but you don't know unless we check. So for people who are dealing more with leakage, but they do empty their bladder, there are other tools. So there's external catheters that can help with urinary containment. For men, there's an external catheter that sort of rolls on almost like a condom. For women, there are these tampon-like suction catheters that really only work if you're in bed, right? Maybe for at nighttime, or if you're not mobile and you're in bed all day, there's these external suction catheters for women that can help. Okay, so that's Bard PureWick is one of them. So
just recently started to be covered by Medicare and Medicaid too. So
yeah, yes. For years I was like, this exists, not covered. Now we're having luck again. Thank God. So external catheters and those kind of devices can be very handy. And then I think Dr. Miravalli, where you asked me about more invasive treatments, right? So beyond all the conservative stuff we talked about, okay, and pills, okay. I also do a lot of bladder Botox and there's bladder nerve modulation. Okay, so there are implants. I tell people it's like a cardiac pacemaker, it's like a deep brain stimulator, right? At the end of the day, nerve modulation is an electrode that regulates your nerve activity. And in the case of bladder, I would think of it as cutting out some of that noise. The bladder's constantly telling the brain, I gotta go, I'm full. It's like regulating some of that noise out of the picture so that the brain can restore normal, bladder filling and bladder function without all that excessive sensory signaling that's happening. And so these are surgical implants. There's one that can go in the low back, like near the sacral spine, way down by the tailbone. There's a new device that was just approved by the FDA that gets implanted in the ankle. And
Dr. Adelstein actually helped develop that device too. So Rush was a center where you're researching it.
yeah.
Lovely.
We also have an office-based treatment, okay, that our PA team helps with, where you get just like a little acupuncture needle in your ankle. You come in for, it's like a lot of visits. It's very non-invasive, but it's a lot of visits, kind of like PT, where you get a stimulation in your ankle. It's doing the same thing as the implants.
Yeah.
So all these treatments are very helpful for urgency, frequency, symptoms. Sometimes helpful for people who don't empty the bladder very well. All right, and those are kind of all, available for like like the next step after pills, or we have a pill, but we don't want to be on a pill every day for the next 50 years. And so there's other options that are a little more procedural. And that's kind of the, 10,000-foot view.
It takes a little bit of time to work out like which of these you would need best. And you asked about some invasive things you might expect at the urologist visit. Certainly, you may have to do an invasive test called urodynamics. And that's essentially we get a functional testing of the bladder to see how well it works. And it's not pleasant. It is, you will be, there's some electrodes that are placed externally, like around the lower abdomen and around the anus. And then there's a smaller catheter that's placed in there that contains a transducer. And we put another catheter in and we fill the bladder up and we kind of see where all the electrical signals kind of respond. And we're able to kind of see where the issue is at the bladder. And so it's very important because, like you said, is that maybe somebody is getting older and there may be something else there that could be contributing to these urinary symptoms. So we could get a reasonable expectation of which of these procedures would help you to what degree.
Excellent.
And are those patient visits, or sorry, Dr. Mirabali, is that something that they come in for a few hours? Is it outpatients, or do they have to be admitted?
First of all, it would never be on the first visit.
Yeah, never on that. Yeah. Pretty rude to do that. Like,
it's usually like, after we've tried some things and we're not getting where we want to be, it's a diagnostic test done in the urology office. And it's like an hour or two, okay, of patient time, largely with a nurse. In our office, there are x-rays involved, and I'm the x-ray technician for those tests. So, but it's just a very sophisticated test of bladder function and dysfunction that helps us parse out, is it that big prostate blocking the urinary tract? Is it just overactive bladder? Is there some spinal involvement of MS having that dysfunction I mentioned in the very beginning? We really can get a lot of detail to help guide us if we're not getting the improvement we wanted with conservative therapies.
Excellent. And you mentioned, JD, that Dr. Adelstein was involved in development of these therapies. And one of the reasons Kathy and I we were so excited to have both of you here is very rare to find a team like you guys. I mean, having a neurogynecologist, a urologist with expertise in neurological conditions, JD being also an expert in sexual health, in men's health. I mean, it's very hard to find teams like yours. So we are very excited to have you a part of the team here and grateful for all the work you do. And on that note, one of the things we are learning in MS and in neurology in general is that time is brain, right? So we know that some of the interventions we have, I will say most of it, they work best when used appropriately earlier in the course of whatever issue we are looking at. Are we ready to say that time is bladder when it comes to urology care? I mean, with that I mean, what is the perfect threshold that patients should have in order to seek medical help if they're having symptoms? I saw a question on the chat box saying, hey, wait a minute. I have to wake up at 3 a.m. every night to pee. Is that a problem? The question is that a problem? Is that too early? Or would you say that's an appropriate reason to see a urologist?
I think, it never hurts to come see the urologist and talk. I will say waking up at night to urinate, the what's normal changes over the lifetime, right? So when you're 20, 30 years old, it's pretty unusual to wake up in the middle of the night to urinate. When you are 60, 70, 80, the percentage of people who are waking up once, twice, three times a night is certainly increasing. Okay. And so it can be a normal part of aging, but sometimes it's not. So, I think that's the kind of thing you'd have to talk to a urologist to get a sense of in the context of all of the symptoms. When you say kind of like, is time bladder, I think only in the case of like, there's urinary retention. We're getting infection, like, bladder infections that are hurting the kidney. Yeah, the earlier intervention probably matters for those sort of symptoms, like in terms of kind of like long-term control and consequences. I think, frequent urination, nighttime urination, other than sleep, I mean, like, losing sleep for years can't be good for you. But in terms of bladder function, the overactive bladder style symptoms, very rarely, do we feel like, ooh, you really should have come to us 5 or 10 years ago. You're in trouble now. Like, no, we can always help. I mean, obviously, we don't want people to suffer and be unaware that there is help available, right? Like that feels terrible when we hear that. So there is help available, so don't suffer. But I don't think it's like causing long-term complications to not be on treatment.
Yeah, I would agree with that for the most part, and I would add this to it as well, is that in urology there is like a kind of a shifting paradigm in the way that we kind of think of benign prostatic enlargement. Whereas for years we'd be okay with just giving people some like medications potentially, or they reach a point if they're catheter dependent and they want to maybe attempt to get rid of the catheter, and then we do a surgery on them. But we have a lot more like minimally invasive procedures now that don't really require like even a stay in the hospital. So I'd say in our professional society, there are some people who kind of are making the argument that like maybe earlier intervention is better because we've historically, and this is in the context of men, really not women, that when we talk about the prostate, we don't really talk about the bladder. And that's what the prostate is directly affecting, and can lead to, a bladder that doesn't work anymore. So I'd agree with Dr. Adelstein that I think some of these symptoms are going to be more not emergent or by any means or like that, but like more obstructive would be probably more reasonable to like consider doing something, sooner rather than later. And obstructive is going to be like a weaker force of stream, and women can get this too. And this is also related to, hey, a person is more than just their multiple sclerosis. There's probably some other things going on too. But we can force a stream and maybe having a harder time starting your stream. Additionally, I'd say that if you're having incontinence episodes and it's interfering with your desire to want to go and be social, that is something that I would recommend maybe considering earlier intervention rather than later.
I think it's super important for individuals just to know the resources and there is hope. There was actually a comment that came through in the chat box saying, nighttime urination, tried biopsies, therapies, medications, but nothing seemed to work. How would you advise somebody who feels kind of exhausted by trying different, avenues and feels lost?
So there is an entity, okay, where nighttime urination is a problem and daytime frequent urination is not. All right. So this is like the person who comes in and tells me, I pee 3 or 4 times a day, but I pee 6 or 7 times at night, every night, right? And it's like this huge discrepancy. Overactive bladder, I like to say, is happening 24/7. Doesn't go away. It's not part-time. It's always there. So when there's such a difference between daytime and nighttime symptoms, there's usually something else going on. So Certainly, we have to talk about fluids, right? Like some people are, for whatever reason, they're at work, they're out of the house, they restrict their fluids all day because they don't want to have an accident, but then they're drinking the entire daytime fluids in the evening. That obviously can contribute to that kind of imbalance. Sometimes folks are taking a lot of medications at night, right? And like taking a couple glasses of water, or maybe they're on a diuretic, right? A water pill that's being taken at night. And that forces the body to produce urine overnight. And those kind of things can cause that kind of discrepancy. Diabetes, okay, and especially like high blood sugar, poorly controlled diabetes. Patients with diabetes can have excessive nighttime urination. They can have excessive urination all the time, but sometimes even worse at night. Leg edema and leg swelling, lymphedema. People get this almost camel effect where when you go to sleep at night, right, the legs are swollen. People are like, no problem. I put my legs up on a couple pillows, right? And the swelling goes down by morning. And that's wonderful for the swelling. However, the body is taking all that edema, all that swelling in the legs, and as it goes away, all that fluid is being processed, in your bloodstream and through the kidneys, and it's turning into pee all night long. So, I tell folks, if you feel like you go to sleep and your legs are way more swollen than when you wake up in the morning, it's as if you're having a couple glasses of fluid before you go to sleep. So then I would advise compression stockings, elevate legs during the day. There's even like lymphedema massage, like boots and stuff to mobilize that fluid before you're trying to sleep. Okay. And if there's not a big visual discrepancy in leg size between morning and nighttime, that's probably not a factor. But for some people, it is. What else? Sleep apnea.
Yeah, very commonly we
Okay.
come in and we're the people actually diagnosing that in people.
So it turns out sleep apnea causes excessive nighttime urination. It's one of the few reversible causes, actually. So if there's any chance you may have sleep apnea, a partner, has told you that there's a lot of snoring or pauses in the breath, or your doctor has said, you have all this daytime sleepiness, the blood pressure is high, it might be worth getting checked out. If you're also someone who is peeing all night long, yes, please go get a sleep test, okay? What happens is if the airway is blocked off and you're trying to take a breath, the chest stretches, the heart stretches a little bit, and the heart thinks it's in heart failure. So it releases hormones, ordering the kidneys, like, bail me out, get rid of fluid, make more urine. Okay, so it's this hormone cascade where there's excessive urine production all night, and then you wake up, that airway blockage resolves, the hormone cascade goes away. Unfortunately, there are some people who have none of those factors I just talked about, okay? The older we get, the more likely the kidneys are to have a natural excessive urine production at night, out of proportion to daytime, and my bladder treatments don't always fix that, okay? There's one medication called desmopressin, okay, that essentially tells the kidneys to pause overnight, okay? Stop making urine. Your kidneys are responsible for balancing electrolytes, okay? And kind of like, right, getting rid of toxins, making sure your blood is balanced. So if we pause your kidneys overnight, okay, this medicine does have a black box warning that it can cause seizures and arrhythmias because we're artificially blocking electrolyte balance. And the older you are, the more sensitive you can be to that kind of side effect. So, unfortunately, right, like this entity, it's called nocturnal polyuria, right? It's like excessive urine production specific to nighttime. We've done all the conservative things, right? Like stop fluids a couple hours before bed. Make sure we're not taking diuretics at night. Make sure the blood sugar is under control, right? Like all those things we talked about. And there's still a huge discrepancy. This pill desmopressin is a consideration, but the folks who are most at risk for this are sometimes the same folks and most hesitant to use this medication, okay? Because we're probably, in older patients, in people who are a little more medically frail, right, heart and kidney function, the risk of that electrolyte imbalance is probably even higher. So it's something I discuss with patients, but to be honest, I don't prescribe it very often. Sometimes when I use those words, right, like seizures and arrhythmias, people are like, never mind, I'm good, I'm cool. But it's very frustrating because it is like exactly what I described. This like imbalance in urine production can come up. So I always
Yeah.
hope for the reversible reasons.
Yeah. Yeah. So, and that's usually the case when they come into our offices, is that, nobody's really kind of gone in to do like these specific deep dives. There's only so much time in the day for everybody's provider, and like it's very hard to miss all this stuff. But and certainly I agree with you too. Like desmopressin is, there is like a natural physiologic thing that everybody decreased. That's a hormone actually, and everybody has a decreased amount of that as they get older. But those side effects are not to be taken lightly. There's very few people. I probably only prescribe it to like 2 people. And I don't even, one of them I inherited, and I don't even think he should really be on it, but it's fine, whatever. But yes, I I think looking at a person more holistically for all these things is going to be much more helpful. I usually nocturia, there's no reason to really go inside and take a look at somebody's bladder and do a biopsy and do multiple biopsies on it. You can usually get to some resolution that's very helpful to at least reduce it. It's probably not going to end up being zero, but if you can have 3 hours of uninterrupted sleep at nighttime as opposed to maybe only getting an hour, that is a remarkable improvement.
Excellent. Well, I know we're getting towards the top of the hour, and before I pass it on to Kathy, I just want to ask you one, no, not a question, but it's actually a comment. In today's session, I have to say I learned a lot, and if any, what I learned is that, bladder symptoms, constipation, sexual symptoms are common in multiple sclerosis, are also common in aging, right? So they that have to be completely related to MS. And what I'm learning is that the threshold for which patients should perhaps seek a consultation with urology is when these symptoms are interfering with your quality of life, when the pattern becomes intrusive in the things you want to do, or you're unable to do because of these symptoms. I also learned that there is a team, an amazing team here, Raj, that can help you diagnose that. So patients don't have to go to ChatGPT or Google to try to diagnose yourself, right? You have experts that actually can help you do that. I also learned that there are many options, anywhere from, non-pharmacological interventions, nutritional interventions, medications, and surgical interventions. But if you have to, just in 1 minute or less, give an advice that perhaps applies to everyone, things they can do to improve their bladder health, or perhaps improve their overall chances of a good outcome, what is your advice?
Yeah, I mean, I think, hydrate well, be careful of fluids that are going to bother your bladder, the things we've talked about. Keep your bowels regular. Just because your bowels have been a certain way for the last 10 years, okay, does not mean that the bowels don't need a little love. And no one talks about bowels. And I don't know, everybody could benefit from like pelvic floor physical therapy, okay, which we kind of glided on, but just so everybody knows, it is not knee and hip physical therapy. It's done by a specialist. It often involves going in a private room, having a pelvic exam if you're a woman, or a rectal exam if you're a man. They are experts in urinary problems, sexual problems, bowel problems. In the pelvis, right? All the organs are close together, and they're often interrelated issues. So it can be very embarrassing. People aren't like, great, I'm so excited to go to pelvic floor PT. But I mean, these therapists are worth their weight in gold. Okay. Like they really, I think, have some life-changing expertise to bring to people. And they do sit there with you for an hour to go through all these details. And I think that's extremely valuable.
Yeah, I would agree with that too. I think the more that we're aware of, like, there's more studies that come out about like the pelvic floor, and we're really very thankful for our colleagues that are physical therapists that specialize in this part of the body. I did prepare like a handout to give to everybody. I can just drop it in the chat. There's resources I use like almost every day that have like zip code location finders for pelvic floor physical therapists. and the sexual wellness therapist as well. So I think those are like a good resource for everybody. Everybody's very frustrated because I recognize that these are subspecialized specialists. So it's very difficult to find somebody that you can get in at a convenient time for you that fits within your insurance. And my only advice for that aspect is that be persistent about getting in with them. And of course, I'll give you like a whole list of these things that I'll share with you. I'll give you a whole list of stuff. I can put it in the chat. Is that okay, Kathy?
Absolutely, that would be fantastic. And
Okay.
otherwise, you can always send that to me too, in case folks run into any problems
Okay.
accessing that. And then we can make sure we send it out separately. So that might actually be easier.
Okay.
So you have my contact information. I think that would be a wonderful resource, and also just for me moving forward with the patients as well.
Definitely. I think providers and patients could both benefit from it. So
Yeah, fantastic. Well, I have to give you both a huge round of applause for covering this so nicely. And again, I think it just does not get covered enough. I know that it can be somewhat embarrassing, perhaps uncomfortable for folks to discuss with their doctors. So thank you for being here this evening and diving into this topic. We really appreciate it. So yes, JD, if you have anything you can send my way, I'd be more than happy to forward it on to folks.
happy to.
And then for everybody on this call, for March, March is MS and NMO, Neuromyelitis Optica Spectrum Disorder Awareness Month. So we will be bringing in some of the great organizations that are out there to discuss their resources available for patients. So I hope everybody tunes back in for March. There'll be more information sent out, obviously, as we approach that date. So I hope everybody has a great evening. And again, many thanks to both of you for joining us this evening.
Of course.
Thanks so much for the invitation. We were happy to be here.
Yeah, very happy. Thanks for your attention.
Thank you.